A very good evening, ma'am. Am I audible to you?
Yes, you are. And am I?
Yes, sir. Yes, ma'am. You are perfectly audible and visible too. When to start the webinar, ma'am? Sharp at 8 o'clock.
Yes, sure. But in this link, is there anybody else going to be there? I don't know actually. And what about the audience link? Would you know that people have joined
Ye-
in? Or
Yes, ma'am. The people have joined in for this West zone, and there won't be any participants apart from you and me, ma'am.
okay, done. And what about
Okay.
the what? You know how many are around?
Yes. You just give me some time. I'll get back to you.
Yes, yes, yes. Another 2 minutes to 3 minutes, we'll start.
Yes, ma'am. There are 13 participants have joined, ma'am.
Okay.
Okay. Shall we begin then?
Yes, it's 8 o'clock,
Oh,
so we can.
okay, okay.
When more join in, when
Ma'am?
more join in, just let me know.
Oh, yeah, sure, ma'am.
Maybe in the chat, just for my information.
Okay, ma'am. Okay, ma'am. Not a problem. Okay, ma'am. So, with all your permission, we are getting started with the session, everyone. Good evening, one and all present here. I am Monalisa from Clarnet, the designated session assistant for the seamless interaction, and Clarnet proudly stands as India's premier digital platform tailored for doctors, providing a wide array of invaluable services. Clarnet is elated to be chosen as a digital partner for this event, organized by National Neonatology Forum. Welcomes you to the webinar on NNF Shine Week 2 West Zone. So, thank you for your patient listening, everyone. Let us get started with today's session, for which I would like to call upon Dr. Uma ma'am to take the session forward. Over to you, ma'am.
Yes. Good evening, everybody. All the first year residents of medical colleges of the West Zone, which is, I think, Maharashtra, Goa, and Gujarat. So it's a very simple topic that we're going to talk about today. And I'm sure everybody has read what the material has come. So this is a fast recap of everything. And Mona Lisa, are we allowing them to be sending questions in the chat or something like that? Hello? Mona Lisa? Okay. Right. So maybe I suppose you can put your questions in the chat and please allow
Yes,
me
ma'am.
to share the.
Yeah,
Are we
yeah.
allowing them to put questions in the chat? Okay, done.
Yes, ma'am.
So I will be sharing my screen. We are talking about the basics, anatomy, physiology, and problems, and with breastfeeding and how do we promote it in the best way? Because you being the first years of a pediatric department, you are the one who are going to be in continuous, uh, just a moment. Is my screen visible? Is my screen visible?
Ma'am, it's perfectly visible. Can you please put this on full screen mode?
Yeah, yeah. But if I ask something, you'll have to respond to me, okay?
Yes, ma'am. Sure, ma'am.
Because the students are not going to be able to respond when I say whether I'm visible or not or whatever. Okay, okay. Where do I put my picture now because it's not being. Okay, okay. Okay. Students, I suppose if there is anything cuts off, or if you're not able to see anything or something like that, do put in the chat. And Mona Lisa, are you going to be able to, will you be looking into the chat? Will you be looking into the chat? Or I have to cover the chat?
Yes, ma'am.
I will be looking into the chat, or you will be looking into the chat if there is any problem.
Ma'am, I will be looking into the charts, ma'am.
Okay,
If there
fine,
are
fine. So
any
because
questions,
I am not going to be looking at the chat,
yeah,
fine.
yeah.
Okay, so we are going to look at breastfeeding. What the time given is it an hour here?
Come again?
The time given is how much?
Ma'am, just a moment.
Is it an hour max?
Yes, ma'am.
See, fine, fine, done. Okay, so we are going to talk about breastfeeding and in places where deliveries are occurring, facility-based newborn care. Now, we all know that breast milk is the optimal nutrition of the newborn baby. Exclusive breastfeeding, EBF, exclusive breastfeeding, and mind you, the figures are very big, can prevent 13% of under 5 deaths worldwide every year. So only if exclusive breastfeeding is given, which means only breastfeeding for the first 6 months, the amount of mortality that can be prevented is a whopping 13%. It seems very easy, but for that, the message of breastfeeding, every word of what I'm going to teach you today, has to be given to more than 90% of all the breastfeeding females of the world. Only then 13% deaths can be prevented. But as it is exclusive breastfeeding itself, the rates are very small. So you can't really, do anything about it. Just a second. Vishal, I'm on a webinar, you have to leave a message. Um, so therefore, it's very important that the message has to go to all and everybody as far as possible has to start giving exclusive breastfeeding. That is only breastfeeding and nothing else in the first 6 months. We'll come to the figures later as far as the NFHS is concerned. Only about 50% of the women are giving. So then the question of, preventing 13% of deaths will not arise. Initiation of breastfeeding within the 1 hour of the breast, along with exclusive breastfeeding, together will reduce it by 22%. That is nearly double of that 13%. So starting breastfeeding within an hour is only going to be possible if everybody, each center, practices what is known as the breast crawl or early skin to skin contact, and the babies are delivered on abdomen. In all government centers, small and big, it has nearly started. But if there are other centers which are not government centers, they have to start all the babies which are normal, good weight babies have to be delivered immediately on the abdomen. So skin to skin contact starts soon after birth. And that along with exclusive breastfeeding can reduce 22% of neonatal deaths. So Government of India has launched Mother's Absolute Affection program to create enabling environment. MA program it is called, to create an enabling environment promoting and supporting breastfeeding in India. Now, here are the figures. As per NFHS 4 survey in 2015-16, only 41.6% were breastfed within an hour. So early initiation of breastfeeding, EIBF. We all the hospitals, 3 hospitals where I worked, I did a thesis for early initiation for breastfeeding, so that once we do a thesis, it gets established, the norm gets established, and that continues, and we have to sustain it. If that gets established, but only 41% it's happening, and only 54% or 50, nearly 55% of children under 6 months are on exclusive breastfeeding. That means 45% or nearly half the children who are less than 6 months have already got something more than breastfeeding. It's a very big figure and a very wrong thing that's happening. So what are the learning objectives of the day today? Enumerate, we'll have to enumerate advantages. We'll have to see what is the correct technique and identify the factors enhancing, what are the difficulties, and also in helping the mothers in expression of breast milk. So there are advantages to baby, mother, and family. Here, World Breastfeeding Week. You're a first year, so I don't know if you're aware. 1st August to 7th August every year for so long now, nearly 25 years, we've been celebrating what is known as the WBW, World Breastfeeding Week. So when in the next, when the next August comes, there will be a theme every year. A theme is given, and a theme-based celebration occurs in every institute, every medical college. And if your place is not celebrating it, we need to celebrate from 1st August to 7th August. Now, what are the advantages of breastfeeding to the baby? Well, optimum growth and nutrition for development of the neonate. Of course, it's the first immunization. Colostrum is like the first vaccine, and therefore it will protect against infection. Easily available and at appropriate temperature. You don't have to heat it, you don't have to cool it, and it's easily available. The mother has to just pick the baby up and feed. So she doesn't have to go through all her work of going there, the baby's crying, going and preparing milk and heating it up, and even of course bottle ka to sawal nahi uthta hai. There's no bottle, but I'm giving it with spoon and so much of work, and she's already tired. And it won't give as much of advantage as the breastfeeding. So there's no question of giving anything else but the breast. Easily digested by the baby, protection against allergies, including eczema, asthma. It is said that the babies who get on to formula very early, they do develop lots of allergies. Emotional bonding between mother and baby, of course, we all know about that. Breastfed babies have a higher IQ, noted in several studies, and it's just not an enigma. This is truth, absolute truth, that breastfed babies have a higher IQ and less chances of adult onset diseases like hypertension, diabetes, coronary heart disease, cancer in later life is also an advantage. Advantages to the mother are many. Uterus, of course, involutes, and postpartum bleeding is less. It is not an absolute 100% contraceptive method, but it does delay the next pregnancy, and the chances of pregnancy are minimized. So it is an inexpensive and natural method of contraception. It lowers breast and ovarian cancer and reduces the workload of the mother. And each of this is not for the fashion, and they are all truth and evidence-based sentences. And what is the advantage to the family and society? It's, of course, more economical than artificial or formula feeding, promotes contraception and family planning. It decreases risk of infections in baby, reduces need for hospitalization, infant morbidity and mortality. So as a whole, the society will definitely benefit. Now let's see what's colostrum. Colostrum is the first milk that is going to be secreted. Let me just check whether if I ask anybody to write in the chat, are they going to write something in the chat? Let me see. Okay. Residents, I would like you all to write in the chat box how many of you have seen, what colostrum looks like. Has anybody expressed that? Have you ever seen what a colostrum looks like? So please write yes or what it looks like. Please write in the chat box. Breast milk produced by women in the first few days after delivery. So I know that you all are paying attention. Let me see how many of you are answering. Only as many are, that means listening or attending, because otherwise you may just put it on and do your work. That's not what we want. Because when we sit here, we also put a lot of effort. So please write, yes, I've seen colostrum and this is what it looks like. So I know how many are attending. Excuse me. Now, what is colostrum? Breast milk produced by women in the first few days after life. It's very thick and yellow, but it contains many things. It contains antibodies, white blood cells, anti-infective proteins as compared to mature milk, and it's not going to be available in any of our artificial milks or even in animal milk. So it is a real first immunization. These anti-infective proteins provide first dose of immunization against diseases to the baby, and it is irreplaceable. It can't come from anywhere else because it is tailor-made by the mother for her own baby. Colostrum has mild purgative effect, helps clear meconium from the gut, and helps to prevent hyperbilirubinemia in the neonate. So the babies who don't feed well in the first few days do develop a higher bilirubin, and may require phototherapy also, because the enterohepatic circulation, when the bilirubin keeps getting absorbed. So when colostrum is given, all this is cleared off early. Why won't it move now? Yeah. Okay. So now what are the recommendations for breastfeeding practices? A baby is born and we put him or her on the abdomen. So it's like early skin to skin contact. And immediately the baby is wiped, the head is wiped, the back is wiped, the front is not wiped. The mother can hold the baby and can put the baby, take the baby a little higher so that the child can already start sucking. So naturally, within half an hour, he will start sucking. There is no other option. And there is no way we can start feeding in half an hour if we do not deliver the baby directly onto the abdomen. So soon after birth, it's not that within 1 hour, that means we can wait till 1 hour. No. It also says within half an hour to 1 hour. I would only remember one word, not even half an hour. Breastfeeding has to be immediate. The baby is on the abdomen, usko wipe kar diya, you take the baby to the breast, and so there's no question of half an hour. 29 minutes hai to abhi nahi dene ka, nothing like that. As soon as possible, immediate. And therefore, automatically pre-lacteals are cut off. The baby has not even come into any other relative's hands. There's no question. Ensure exclusive breastfeeding for the first 6 months. So once the baby is put so early, and the first half an hour is the time when the baby is maximally alert, and the mother has also had a relief from pain, and she feels so good to hold her baby that the bond becomes the best at that time. And when the bond is the best, the feeding gets established the best if it is started so early. So later on, there will be hardly any problems in adjustment of the mother and the baby for breastfeeding. Breastfeeding both during day and night, at least, and we'll see in the physiology later what is the importance of night feeding. Maybe in the early few months. Later on, one does not have to, means once the baby is 3-4 months or a little older, it's okay if a late feed that's given at 11 o'clock and the first feed is given at say 5-6 o'clock. So both of them get a good night's sleep, but that's later. But first few months, the baby has to get night feeds because that increases the prolactin secretion, and therefore the milk secretion increases. Allow the baby to feed at one breast till she stops sucking and release the breast, then offer. I mean to say, let the baby empty one breast. Once the one breast is emptied and there's nothing much coming and the baby still wants to feed, then you give on the other side. And now the baby doesn't want to feed on the other side, then the next time the mother feeds on that other side first and then comes to the previous one. Some of the educated mothers, what they do is they give little on left and little on right. That means they're only going to be feeding for milk, and 4 milk is very thin and the weight will not increase. So the baby has to be fed 4 and a hind milk together. Okay. Adequacy of milk intake. How do we know that the baby is getting enough milk? Sometimes the mother, educated mothers have a problem with that. They will say, I don't know whether he's getting enough. But then we'll ask the questions. We'll say, does he live on his own? Yes. Does he sleep well or is awake and playful a little bit? Yes. Does he pass? How many times does he wet his diapers? At least passes urine 6 to 8 times. And then we will be weighing this child every day as long as in the hospital, or even after that, at least every week. So we know that he has to gain 1%, 20-30 grams per day, we will say, but 1% of his birth weight. If he is 2.5 kg, 2500 grams, then he'll gain 25 grams a day. And if he's a 2 kg, he'll gain 20 grams a day. If he's a 3 kg, he'll gain 30 grams a day. If he's 3.5 kg, he'll gain 35 grams a day. So if I'm going to weigh him after 7 days, I know exactly how much he should have gained. Suppose it's a 3 kg, and after a week, he's just become 3.2. Am I going to feel happy? He's supposed to gain 30 grams a day. So calculate 30 grams a day, 7 days, 210 grams. So 3.2 is fine, right? Okay. So in the first 3 to 4 months after regaining birth weight. So first 3 months, he's going to gain so much. So if that's happening, that means she's secreting good. Initiate complementary feeds after 6 months, and breastfeeding must be continued till 2 years. Now let's come to the anatomy. It has glandular tissue and it has fatty tissue. Okay, so you can see here, if you see this, so this alveolus, each one, the one of them is being magnified. So you can see this outside thing is the muscle. So once the oxytocin comes, the muscle will contract. And the layer beneath this is the milk secretion. So when the prolactin is secreted, this will secrete milk. Oxytocin will come and contract the muscle, and therefore the milk from here will come and get collected in the lactiferous sinuses, in the areola. So you can see very well here, if the baby only suckles a nipple, he will not get anything. He has to take the whole of the areola and do a milking movement. Only then he's going to get the milk. So these are the tissues that we see. And in between, holding these glandular tissues, is the fatty tissue. Now, what are the reflexes involved in breastfeeding? Sucking, rooting, and swallowing. So once the mother touches the baby's mouth, with the breast, the baby's cheek, if she touches, he will immediately turn towards. And if the breast is touching here, he'll turn. If the breast is touching here, he'll turn. If the breast is touching here, he'll turn. That is the rooting reflex. Sucking comes at around 34 weeks of gestation, and the sucking is established. Swallowing is established a little earlier. That is why may have already seen as first years that even in preterm babies, when we start feeding, first we are giving by tube, and then we'll give by spoon, so that only he doesn't have to suck, he has to only swallow, and then only sucking. So what happens? Rooting reflexes, as I said, he will turn, and sucking and swallowing. Okay, swallowing means he'll suck a number of times, and then he will pause for a short while so that he can swallow. And it will appear as if the baby is stopping, but he will immediately restart. We don't have to do anything about it. Okay, now let's learn a little bit about prolactin and oxytocin. So here, prolactin, what happens is, once there is a stimulus, the baby suckles, the message goes to the brain, to the pituitary, anterior pituitary, and that will secrete prolactin in the blood. And that blood will go and cause the milk production in the gland. And if secretion increases at night by suckling of the baby, and when the breast should empty, the baby should suckle, and once the baby suckles, the prolactin releases, and it is said that there is increased prolactin secretion in the night. So if somebody avoids night feeding in the early part of the baby's life, then of course there will be problems in breastfeeding. If the mother says, okay, ratre to mani hongi jau, we'll give something else, and the day I'll give, her breastfeeding itself will not get established well, because the prolactin secretion will suffer. So now, what are the enhancing and the hindering factors for this milk secretion reflex? Emptying of the breast. Once the breast is emptied, baby suckles, and then even if it's a sick baby, for example, and we are expressing milk, that also is an enhancing factor. And night feeds, they are enhancing factors for secretion of prolactin in the blood. And impulse goes from the sensory impulse from the nipple to the brain, anterior pituitary secretes in the blood, and the blood comes here and acts on the glands. But what is the hindering factor? Bottle feeding, incorrect position, painful breast, garbad. Okay. Now, what about the milk output reflex? What was the other one called? Milk production reflex. And now we're talking about milk output reflex, and that is the oxytocin reflex. That is secreted by the posterior pituitary. Again, what is the stimulation? There, the suckling was the stimulation. Here, the thought itself is the stimulation. Sound of the baby, sight of the baby, confidence. So if the mother is, say, in hospital, working in the hospital, she hears some other baby crying for milk, that itself, oxytocin will get released, and she will start producing, and the clothes will get wet. So that is how it happens. Things like a lovingly, sound of the baby, sight of the baby, and inhibited by worry, stress, pain, doubt. Nothing of the short should go on. Even if she has to start working after some time, we can always establish breastfeeding, which is established. We can continue by asking her to express some amount, put it into the fridge, and then come back home and feed once, and again put it in the fridge and come back home. So it will be either breastfeeding or breast milk feeding. We can always help them with that, so that the worry and the stress of work also is not there. Of course, early part when the baby is just born, the question of working doesn't arise. So what is the position? Yeah, you can see here, very well supported. The body, the neck, and the head are all in the same plane, well supported. Baby is turned towards the mother, and the baby's tummy is touching the mother. So there's no I call it the latkoing baby. If the baby is only the mouth, the head is in the supported, and the baby is latkoing on her lap on a nice looking, beautiful feeding pillow or something like that, and the baby is not turned towards the mother, baby's abdomen is not touching the mother, that is not the right position. Even if she has a pillow on the lap, she'll have to pick the baby up in her hands and turn the baby towards her, support well, and all the body, the neck, and the head are all in the same plane. And here you can see that the baby's mouth is wide open, lip will be outward turned, baby's chin will touch the breast, and most of the areola is inside. This thing is a little overlapping, but you can see that the mouth is fully open, very little of the areola is seen above, nothing will be seen below. Lip will be outwardly turned and the chin will be touching the breast. Okay, now what can be problems during breastfeeding? Can you see here? This is a flat nipple, this is an inverted nipple. A big problem because the baby doesn't have anything to hold on to. So, inverted or flat nipples, it can be detected in the antenatal period and it can be taken care of in the antenatal period and it should be taken care of. Sore nipple. In the sense, if the baby is not having a good position or a good attachment, what will happen is the baby will only bite on the nipple and he won't get milk because the milk is in the areola. And if that happens, then the nipple will become sore. Other reasons for sore nipples are the mother is very obsessed with cleaning every time she's cleaning with soap and water. It's a very, very, sensitive area. We don't really have to do that. She can just wipe off with a napkin or something like that. But she doesn't have to use soap and water and all that. That also can cause a lot of soreness. But mostly it is because of the wrong position and the wrong attachment. Third is breast engorgement. Breast engorgement will occur only if wrong position, wrong attachment, baby is only biting the nipple, baby is not emptying the breast, and then there will be collection of milk in the breast. And if we do not relieve the engorgement either by, we put warm clothes, warm napkins around and express it out and then make it a little softer and again put the baby to breast, then that will be released. But if we fail in that, then it will go towards an abscess. And abscess means again there will be draining of the abscess and a big problem because then she's in so much pain and stress that her secretion itself may decrease. But if that doesn't happen, definitely we should continue to feed on the other breast. Some people may feel I have less milk supply, not enough milk, and uh, what is required for that is only reassurance. But it sounds very simple. We'll have to reassure that, see, the baby is sucking well, baby is sleeping well, baby is playful, baby's weight is increasing, baby is passing urine. So it is, and sometimes I have found mothers, what they do is they'll buy a pump only for that. And they'll every time, sometimes they'll completely empty and see how much milk is coming and how much is secreting and he'll calculate. All that is all humbug because she won't secrete or she won't, when the baby suckles, she'll really secrete and there'll be oxytocin and prolactin. And when she's just trying to express and see, this is the amount I'm secreting, you don't really have to do that. Never ever to do. Pump only for knowing how much you're secreting. You don't have to know. The baby will tell you, I'm satisfied, I'm sleeping, I'm gaining weight, I'm passing urine. The baby's indications are enough. And common causes of true milk production is just give me a moment. There's a little noise outside. Just give me a moment, please. Just give me a moment.
Ma'am, your
Yeah.
voice is yes.
No. I just asked for a moment. because there was noise. My grandson was yelling away, so I just went to tell him.
Okay, okay, sure, ma'am.
Yeah, I said that. I said, give me a moment. Yeah. So now, so this is the treatment for flat or inverted nipples. This is known as the Nirmala Kesari method. Nirmala Kesari was a pediatrician in Karnataka. She was a good friend also, and she invented this very simple technique of cutting the syringe on one side and putting the plunger, taking the plunger from here and putting it from inside from here, and this is attached to the nipple, and a negative pressure is created. And as soon as some amount of nipple comes inside this, that can be offered to the baby, and then the baby's pull itself will help in bringing out the flat or the inverted nipple. Okay, now breastfeeding in preterm low birth weight babies. Is it going to be different? If the baby can suck and swallow and the breathing is coordinated, which is around 32 to 35 weeks, then we won't have to do much. But preterm milk has got a higher protein, calorie, and protective substances, and mother should begin expression within 6 hours of delivery. If the baby is small and if we do not expect the baby, to be able to suck, we can start expressing at 6 hours itself, and encourage the mother to visit and touch care the baby. So once a mother should go and change her clothes and touch the baby, get some sense, and that will actually release her oxytocin. So prolactin and oxytocin, and then she's encouraged to express the milk. Which are the babies who may require expression of the milk? Specifically, if in an ICU, then a preterm baby, a low birth weight baby, sick baby, for some reason the baby is not able to take direct breastfeeding, working mothers, and to relieve engorgement. These are all the reasons for which we may have to really pump out uh, manual or even using the pump. And EBM can be kept at for 8 hours outside and 24 hours inside the fridge. Most of the centers, I'm sure, have put up these 10 steps to successful breastfeeding. So I'll just read the headings. And if not put up, then kindly ensure that the department puts up these. Hospital policies have to be there, for feeding. Everything is written there for KMC, etc., etc. Staff competencies have to be built in. Antenatal support for breastfeeding. There has to be a corner, there has to be a room in the antenatal OPD itself where there is somebody sitting there who is supporting breastfeeding, care after birth, and support with mothers with breastfeeding, etc., etc. Rooming in, responsive feeding, bottles, treats, and pacifiers not to be seen at all, and on discharge also some advice is given to the mother. So the same 10 steps has been written here. International Code of Marketing of Breast Milk Substitutes. That is something which you need to know about. There is an International Code of Marketing of Breast Milk Substitutes. That means the formulas, and they cannot claim unnecessary things, putting a chubby baby there and saying this is better than breastfeeding and all. No, they're not allowed to do that. Okay. And these codes came in a long ago, about 2 to 3 decades ago, and all the milk producing uh, companies have to follow that and have a written infant feeding policy which is communicated to the staff. Establish ongoing monitoring data management systems. Most of the places and medical colleges will have to talk about that, about the CLMC and the lactation support units, etc., etc. Ensure that the staff have sufficient knowledge, competence, and skill to support breastfeeding. Discuss important management of breastfeeding with pregnant women and their families, even antenatally. Facilitate immediate and uninterrupted skin to skin contact soon after birth. And I keep insisting on that. Support mothers to initiate and maintain breastfeeding and manage common difficulties. Do not provide breastfed newborns any food or fluids other than breast milk unless medically indicated. Nothing has to be given. No water, no fluids, no nothing. enable mothers and their infants to remain together, rooming in. Fortunately, in our country, it's always been there. And in many places where I've seen outside, it used not to be there, but now they are also going towards rooming in. Not only rooming in, we call it bedding in. It's the same bed, not in a ghodia or something like that. Support mothers to recognize and respond to their infants' cues for feeding. Counsel mothers on the use of and risks of feeding bottle teeth specifiers. Sometimes what happens is once I went to the wards and everybody has got a pacifier, and I wonder what happened. And so sometimes you go and everybody will have a breast shield. Yeah, this is easier. God alone knows. Somebody selling outside, ek mother ko kuch tukka aaya. She'll say, well, this is good. And they, so whenever anybody is taking rounds in the postnatal ward or in the NICU or something, one has to keep your eyes open. Something she'll be hiding here and there, and some idea she'll get and she'll buy all these things. So we have to be very careful in telling them that this should not happen. And coordinates discharge so that parents and their infants have timely access to ongoing support and care. So even during discharge, when they are going home, and if it's a small baby, and you have to give it over to the Asha or the Anganwadi or the health worker in their area, all that has to be done prior. Now, under National Health Management, lactation management centers are a must, and they're started at 3 levels in the country in government centers. And the highest will be the Comprehensive Lactation Management Center, CLMC, which used to be called or are still at times called the Human Milk Bank, because that's become a terminology that everybody knows. But it's not just banking, but there is so much more to it that the center does, and that is why it has to be called a Comprehensive Lactation Management Center. The other one is the lactation management unit, where sometimes they don't have certain equipment of processing, but they can have a storage unit, like you have a storage unit of blood or something like that. And lactation support unit is also very important. She may not have any equipment or anything, but the support that somebody has to give to the mother soon after, because she's not born with the baby born on one side, and the mother is not born suddenly with all the knowledge of how she's supposed to breastfeed and what she's not supposed to do and how she's supposed to hold the baby. And nobody's going to, if nobody helps her, then that's not fair. So lactation support unit, somebody trained in lactation management has to be available in all places where any delivery is going to occur. So CLMCs are present in medical colleges with NICU and district hospital. And lactation management units are there in some of the district hospital, large sub-district hospitals with functional SNCUs. They should have a lactation management unit, and if possible, some storage unit, or at least if not anything for storage, but they can help the mothers to, to express having equipment and use it just as mom, that is mother's own milk, rather than to process and to store it. For giving mother's own milk by expressing and then giving it to the baby, we don't need any processing. But for that also, a lactation management unit is required. She cannot be allowed, she can't do it on her own. And it's all delivery points. You have to have what is known as the lactation support unit. So somebody has to be there to help the mothers. And this doesn't happen even in private nursing homes, sorry to say, because it's only when you go to the highest nursing home also. Nowadays, they've started keeping these lactation management people, because we get these qualified people now. But otherwise, it would be the Ayabens who will come and say, they are the ones who are in and out of the room, and they will say, do this and do that. And, they will give some wrong information, and they are not the people who are actually lactation support people. Okay, so now what does the CLMC do? I think most of the, sorry. What does the CLMC do? Now, the CLMCs are seen in all medical colleges, and if some don't have it, they have to have it, and in big district hospitals also. I come presently from a private medical college, and we have been able to establish a lactation management, human milk bank and the CLMC for the last 1.5 years. It cost a lot of money, maybe 35-40 lakhs, and it won't give any returns. A private medical college is always going to think about the returns. But fortunately, in Parle University, I have the director who's was once upon a time our very prized student, as well as she belongs to the community medicine field, and therefore was so much for breastfeeding and all that I was fortunate to be able to make them spend that money, and I got the space. I have people who are doing it, so all our babies, hardly anybody will get a formula. So it's there. What does it do? Comprehensive lactation support and management for all mothers within the hospital. So even in the postnatal ward, there are people from here who will go and take talks for them, go and see in rounds if there is any engorgement. Aajkal, though we don't see any engorgement because the lactation management center is always taking care of them. And if they have some wrong impressions, the mother will suddenly start crying because it's a very labile, it's a very emotionally labile period. And she'll say, "Oh God, I'm not secreting." So she needs somebody to stand there to support her, to talk to her. That is all part of the CLMC's job. So and then she will say, "Okay, come to the center, and we'll once or twice allow her to express and then feed, and then once she expresses and then she says, 'Oh yes, I am producing so much.' That gives her a confidence. Otherwise, she doesn't need expression, but just for confidence sake. And then the milk is given as a mom, by spoon. And if the baby doesn't need it also, that can be just donated, and the baby can be put directly on breast, because just because it's pulled out and we have to give by spoon is not necessary, and she still can directly feed. That can be just taken into the human milk bank. So it depends upon how much she's secreting, how she would like to do it. And so a lot of confidence building exercises are given. And there are facilities for collecting, screening, processing, storing milk. And these all PDHs, that is pasteurized donor human milks, are available for babies whose mothers have not come in, or the mothers are sick, or mothers are not secreting for whatever reason. And when the mothers are not around, so still the babies in the NICU will get, uh, you know, mother's milk. Facilities for expression and storage of mother's own breast milk also should be there. That means a lot of babies, though it's human milk bank, but most of the mothers who are there will be using their own milk, so we don't have to process it, but we'll be expressing it, putting a name and storing it, and giving it to her own baby. Lactation management unit is at secondary health level facility like district hospital with SNCU to provide lactation support, collect, store, dispense, but only mother's own milk. So there is not going to be any, screening and processing and, getting the cultures done and etc. Only mother's own milk. So no processing required, just storing required. And sub-district hospitals and all, some support of breastfeeding is required, and that is the lactation support unit. So even the smaller one, it is very important to have a lactation support unit in every place that delivers. So private nursing homes, gynec nursing homes who are delivering should also definitely have a person, if possible round the clock or at least during the daytime, who comes and supports, who spends time with every mother and gives her support, allays her, builds up her confidence, her fears are gone, and a lot of maybe us who are of a different generation feel that we missed this. Even being pediatricians ourselves, definitely would have loved to have support of lactation people. So you imagine what is the necessity of these people, to what extent. It's a good career for people to take up after MBBS or even otherwise, to learn lactation management. And there are now lactation management consultants available, even practicing outside. Yeah. Oh, we've come to the end of the presentation. I can stop sharing now. Can I stop sharing? Okay, so now, ClearNet, is it feasible for anybody to ask questions? Can they come in and ask? Is it possible?
Yes,
Or
yes,
they can?
ma'am.
Okay,
Yes, ma'am.
so
Let me
they
check
can
the
raise
chat
their
box.
hands, and come in and ask if they wish to.
Ma'am,
We can discuss. There are others. I can see some of my colleagues, if they want to share something, are also, it's open, as well as if there are any questions in the chat box. No, there are no questions in the chat box. But if anybody wants to come in and ask, we are open. Is there anything?
so far, ma'am, I don't see any questions.
Okay.
I
It
would
was
like
a
to yes, I would like to request all of you, if you have any queries, you can put down the question to the chat box.
this was a simple topic, so I'm sure that they won't have real queries, so to say. If not, then you'll have to permit me to end the session.
Yes, ma'am. If you want to do that, you are like permissible to do so, ma'am.
Okay. Thank you.
So, thank you so much, everyone, and thanks to Uma ma'am for the wonderful session and deliberations as well. So, with that, we would like to conclude the session over here, and really looking forward to hosting you again, ma'am. Thank you so much.
Thanks a lot.
Welcome, ma'am.